Welcome to the Man Cave Podcast with Dan Casper.
He is Dr. Austin Crow, Chippewa Valley Orthopedics and Sports Medicine, joining us here this morning. Austin, how was fishing last week? Did you have any luck?
Well, we did all right. We had caught a lot of fish. They were just small, but it's sometimes just the act of being out there and relaxing and having a good time is just as much fun. But yeah, it's always nice to catch big ones.
Yeah, absolutely. Well, good to have you back on because last week we had the NFL Combine, and one of the big stories to come out of the Combine was potential number one overall pick Abdul Carter, the defensive lineman from Penn State. There was a report that after medical evaluations, it revealed a stress fracture in his foot. And then there was some debate whether he was going to have surgery or not. His team opted not to have surgery. So, I mean, what are your thoughts when you heard about that, especially when it's potentially the number one overall pick? We've talked about foot fractures and such. I mean, is that something that would give you a little bit of concern that it was revealed that he had a stress fracture in his foot and he's not having surgery?
Yeah, so it's likely a Jones fracture, which is a precursor to that. Obviously, in this case, is just a stress fracture in that area. So it's in the fifth metatarsal, so on the bone on the side of the foot. There's an area that has it's what we call watershed area. So the blood supply, some of it comes from the tendon on the kind of proximal end. Some of it comes from blood vessels more in the central. So it leaves a little area where it doesn't get great supply from either spot, and that area is prone to injury. And the problem is once the injury occurs, it's not great at healing. And so that's why that can be a real tricky injury to get to heal correctly. So when you see an athlete with that, your options are as follows. You shut them down, boot, limited activity, and try to get that bone to heal. Or you put a screw across it. So you make a small incision on the side of the foot, and then you put a large, usually titanium or metal screw right down the pipe. And that, of course, makes a rigid construct across it, which takes stress off that area. Surgery, if surgery occurs, it's going to be a longer recovery compared to if it healed on its own. The problem is if you try to get it to heal on its own, it may not heal, and therein lies the rub. So at face value, yes, there's always a concern when you have a stress fracture, will it heal correctly? I will say, I'm sure he's had a thorough evaluation. If the MRI didn't show that it's a real severe one, non-operative certainly makes sense, because going in with a screw is not without issues as well. Often people get irritation, so you have to go back and take the screw out. Sometimes people can have problems after the screw comes back out. So it's not like that surgery is a guaranteed win. Now, I would say if it actually completed, meaning it's not just a stress fracture, it was a full fracture, I think that would be much more likely to be treated with surgery. So in this case, definitely newsworthy, and certainly is going to give some teams the ability to say, wait a minute, let's take a closer look at it. But with a thorough evaluation, they'll have MRIs. I'm guessing it's going to be something that shouldn't be a long-term issue for them.
Now, when it comes to foot injuries and such, when I don't know if this is a similar one, but whenever I hear foot fractures, and I think of the Liz Frank injury,
Mm-hmm.
is that the worst one? Is that something similar, or just in a different part of the foot?
It is in a different part. That's the midfoot, and yeah, that is a bad one. Yeah, that is absolutely career-threatening. So that's an injury where you get that fixed, and it's to put it bluntly, a crapshoot. Sometimes those heal okay, sometimes they don't. The overall track record for that one is definitely not nearly as good as, let's say, a fifth metatarsal fracture. And there are a couple bad actors in the feet. There's a navicular bone. There's been that's what cut Yao Ming's career short. Was a stress fracture, and eventually I think that went on to AVN. What's called avascular necrosis, where the bone starts to die essentially. So there's a couple different injuries of the foot that can be quite serious. Certainly the most common by a mile would be just a standard sprained ankle, which we see a dime a dozen, but those can be problems in and of themselves. So, the foot and ankle are definitely a host to a number of injuries that keep us busy over at the office. But certainly, if you're talking about severity, Liz Frank ones, they are really high up there as far as, things that you're worried about being really career ending. So those are ones you never like to see. But luckily, they're rare. Those aren't some the ones that you see come through very often. So it's an uncommon injury, but one that is quite severe.
I want to go back to apparently this just came out the other day, but the Super Bowl Brandon Graham, the Eagles defensive end, who actually played in the game, and he was recovering from a torn triceps, but a report said that he actually retore that triceps again in the Super Bowl. He only played 13 snaps, so not sure where, at what point in the game he tore it or retore it. He's already had surgery. Now, there is speculation he was going to retire anyways, but the fact that he retore it, is there any, is it a harder recovery? Is it a longer recovery? Is it a similar kind of path? Is there any other issues with that retore that could potentially maybe make that decision for him?
Yeah, I mean, the answer is absolutely. It's more challenging in basically every facet. So first off, once it tears, the first one's probably a relatively clean tear. The second one, once you have them anchored back in, there's anchors and sutures that are running into that triceps tendon. So when it tears, it's probably going to have like an atypical tear pattern because there's going to be sutures holding tendon. It's going to rip around that. And then if you also take a step back and think about what that arm's already been through, so you have the injury, you have the surgery, the recovery, it takes a while to bounce back, and it probably never got back to fully 100%. Anyone out there who's had a major tendon injury, so whether it's Achilles, whether it's quad, whether it's patella, whether it's tricep, or whatever it is, it may never get back truly to 100%. So then now you have an injury on top of that. So, yeah, there's multiple reasons why that is not an ideal situation, and that certainly could be something I'd push him to say, look, maybe it's just time to hang it up. Is it impossible to come back? Absolutely not. There are people who come back from re-tears. We see them, but I can tell you the success rate for repairing a revision repair is definitely lower. Whether it's getting the hardware to work, whether it's getting the tendon to heal correctly, those are all things that are more challenging in the revision setting.
I want to move over to hoops because we've seen a rash of injuries in the NBA. Kyrie Irving, obviously, with his ACL, and then Jalen Suggs. The reason I want to bring this one up because it was the way, and I don't know if this is accurate phrasing of this, but Jalen Suggs is done for the year. He's been dealing with a knee injury for the last month, but he, according to this, said underwent surgery to take out some cartilage in his knee. Is that a thing? Take it out? Because we've talked about cartilage a lot when it comes to ACL and knee injuries. Is it a thing to take out cartilage, and that's the method to get him back on the court, if you will? Yeah,
the answer is yes. So we only take it out if it's an unstable flap. So, and just take one quick step back to just review anatomy quickly. So generally when we're talking about the cartilage in this sense, we're talking about the hyaline cartilage or the articular cartilage from the end of the bone. So that white shiny stuff that covers the ends of the bone. There's also fibrocartilage, which is meniscus tissue, and sometimes people get those two confused. But in this circumstance, they're certainly talking about the cartilage in the bone, and that is, we've talked about that at length. That is a very serious issue because once you have damage to that does not heal very well, and then you have to do different procedures to try address that, and usually get filled back in. The most rudimentary would simply be removing it and then debriding. We call that a chondroplasty. So taking the loose piece and doing a chondroplasty. What he's having done is also something called a mosaicplasty. So mosaicplasty is where they take little plugs of bone and cartilage from his knee. They'll move it from one spot that's kind of not as important and move it to more of the prime real estate. So his is in his trochlea, which is basically the groove where the kneecap rubs against. So they'll do little plugs and try to fill it in. That procedure works pretty well. I do it fairly routinely on patients, and we have a good success rate. Obviously, doing it on a person who's a weekend warrior and just trying to get back to life is one thing. Getting someone to go back to the NBA is another story. So it will be interesting to see. But, I will say historically, a lot of these NBA, NFL, whatever players are talking about, when they have cartilage procedures, they try to be minimally invasive, and they would just try to do cleanups, microfractures, things like that. We are seeing more of these de novo procedures where you're grafting cartilage in, or mosaicplasty, which is a form of called an osteochondral allograft or autograft. So they are trying to do more to salvage these knees, and we just don't know how it's going to work out. Because what they're going to put their knees through again is not what the average guy or gal is going to do on the weekend. So it'll be interesting to watch this. But so they didn't just take it out. So they took it out, but that was because that there was either a flap or now a defect, and then they went back and harvested and transferred cartilage into that spot.
Interesting. Oh, so last one for you here, and it's probably the biggest unknown in the NBA, Joel Embiid. Right now, he's done for the year, and I was reading on NBC Sports, or not, NBA.com, excuse me, and the phrasing they say is that the 76ers say they are working with medical experts to determine an exact treatment plan. Joel Embiid said, I think the straightforward answer is that when you've got something that's inconsistent, at some point you've got to do something about it. We don't know what it is. We're looking into every option. So, I mean, it paints the picture. They don't know exactly what's going on with his knee. What are some of the, for tests, or what are doctors trying to figure out? Like, what are some of the options that they're looking at, or different things to do to try to figure out what's going on with Joel Embiid's knee?
Yeah, the rumor I had seen floating around is that it's due to a deficient meniscus. So he's had meniscal surgery in the past, and they're talking about doing a meniscal transplant. So that's where you take a cadaver meniscus and put it in the knee, and that is a surgery that we do as well. So it's not super common. I mean, I only do a handful a year, but compared to like removing or repairing meniscus, we do a couple of those a week. It is a much less frequent surgery, but the challenge is you're taking a cadaver one, trying to get it to heal back in place, and then even though the body does grow into the periphery of it, it never fully integrates, and so the risk of re-tearing it is fairly high. So just to my point about being more aggressive with cartilage, I mean, certainly I don't know of any other professional athlete that's had a meniscal transplant that's come back. And to take it one step further, you can't just take any meniscal fragment and put it in there. It's got to match. And so I think it probably would take a while for them to find a knee that's exactly like Joel Embiid's, because I'm sure he is made different than the rest of us. So that's what I had heard. There was a doc that was talking about it. So I don't know what his source was exactly, but to answer your question explicitly, I mean, they're going to be doing MRIs, physical exams, listening to the patient talk about what's going on. But with his history, certainly it's going to either be a deficient meniscus or cartilage or both. And then once you get into that situation, especially with a big man, if you start having cartilage problems, I mean, the list of NBA players whose careers have been cut short by cartilage is a long list. So that, unfortunately, could spell the beginning of the end. If it is just a deficient meniscus and not cartilage yet, could a meniscus transplant work? Yeah, I mean, I've done meniscus transplants and gotten patients back to high school and college sports, so it is possible, but it is certainly not a guarantee. So it will be interesting to see how that one plays out. They are playing it a little bit, tight-lipped. But again, what I'd heard was potentially a meniscus issue and a meniscal transplant. So that would be a long recovery, potentially even, out part of next season unless they do something really quickly. But time will tell.
Man, I mean, when you were talking, I just had flashbacks to, I know it's probably a little bit different, but Bakhtiari and his recovery from that knee. So
I mean, that explains it all right there. I mean, it's more than one thing, but as soon as you get that cartilage element involved, I mean, that is always the challenge. I mean, when I talk to my patients and families after surgery and they don't have cartilage issues, I always tell them, like, look, we had this, that, and the other, but the good news is we have good cartilage, and that's the foundation for any joint. So I don't care what joint in the body you're talking about. If you have good cartilage, you can often salvage the situation very well. Once you start getting into significant cartilage damage, it is a much more challenging scenario where you're trying to restore function and activity, and then really, honestly, pain relief. I mean, because then you start getting into, I mean, you're really talking about post-traumatic arthritis in these young players. I mean, people in their 20s that are dealing with early arthritic changes. I mean, that's a tough spot to be in, and that's one of the real challenges. And someday we're going to have, whip up a stem cell shot, shoot it in, and the knee will grow back or something, but we're not there yet. So we're still stuck with the scenario where we're trying to figure out how to address that.
Man, he's Dr. Austin Crowe, Chippewa Valley Orthopedics and Sports Medicine for Inside the Training Room. And as always, if you missed a little bit of a portion, we've got that up on our podcast and such. Dude, appreciate the time as always, man. You have yourself a fantastic weekend. Enjoy the weather, too, coming up, it sounds like. So maybe. Yeah, we'll tell you. It's been a bit of a whirlwind as far as ups and downs. But, yeah, spring should be around the corner. Got to get that little one out on the golf course here soon, too. So absolutely. All right, dude. We'll talk to you soon, okay, bud? Take care. You got it. Dr. Austin Crowe, Chippewa Valley Orthopedics and Sports Medicine.